Good morning, and welcome to this iThrive sponsored podcast entitled Increasing Recruitment of African American Subjects into Research Trials. iThrive is the name given to the Clinical and Translational Science Award currently held by the University of Virginia, Inova Health System, and Virginia Tech Carilion School of Medicine and Research Institute. And these are all partners located within the Commonwealth of Virginia. I'm Jim Nataro. I am Chair of Pediatrics at UVA, and I am co-chair of the iThrive Hub Research Capacity Corps, the purpose of which is to increase soundness and rigor in clinical research across iThrive. Now, we all want our clinical trials to produce data that are valid and applicable across the widest population, but often our studies do not reflect the population of the US. One of the problems is consistent underrepresentation of African American populations in clinical trials. We are taping this broadcast on June 19th, 2020, and appropriately, on the day when we celebrate the end of slavery in the US, we would like to discuss how to increase recruitment of African American subjects. Joining me are Dr. Joycelyn Cudjoe. Dr. Cudjoe is a nurse research scientist at Inova Health System in Falls Church, Virginia. She completed her PhD in nursing at Johns Hopkins School of Nursing in 2019. Her research interests include mixed methods approaches to health literacy, chronic disease prevention, and psychosocial determinants of immigrant and minority health. Welcome, Joycelyn.
Thank you.
We also have Ms. Peggy Scott. Ms. Scott is a highly experienced clinical research coordinator with the UVA Emily Couric Cancer Center. She's a leading member of the iThrive Clinical Research Advisory Committee and is focused on accrual of minorities and underserved residents in our catchment area. Welcome, Peggy.
Thank you, Jim.
And lastly, we have Dr. William Gerald Teague, or Jerry Teague. Dr. Teague is the Ivy Foundation Distinguished Professor of Pediatrics and head of the Division of Pediatric Respiratory, Allergy, and Sleep Medicine at UVA. He is a world-renowned expert on severe asthma and has performed community-based studies of asthma for over 30 years. He is also a member of the iThrive Clinical Research Advisory Committee. Welcome, Jerry.
Thank you.
So I would like to start with building some context. So what are some of the problems or impediments to recruitment of African American subjects? And may I start with you, Peggy, please?
Thank you so much. Jim, I think there are several factors that play into the issue of African Americans and clinical research. I feel as though as a recruitment and outreach specialist in the Cancer Center in the past 3 years, one of the things that I've found is the barriers are great. The obstacles include things like trust amongst our healthcare professionals and our patients, building relationships, the fear that goes along with being a research candidate, as well as coming into the healthcare system, communication, the cultural aspects, sometimes things like translation services for language issues, distance for travel, cost for expenses to be able to reach our facility. So there are many factors that are barriers to our accrual of African Americans to research. But trusting relationships I consider a huge component of why we see so few of our African Americans participating in clinical research.
Thank you. Anybody else want to add to that?
I would like to add to that as well. I strongly agree with Peggy that mistrust, lack of communication are the key issues. And also, in my experience recruiting African immigrants and African American women for cancer-related research, it also the stigma associated with the type of research that you're doing and the research topic. So, for instance, if you're studying HIV or you're studying cancer, there's fatalistic beliefs that are associated with both of these topics. And so the type of research question also becomes a barrier for most participants.
And I think I could add to Joycelyn's comment, is that trial design, when we develop research trials, it's not often that the African American population is included in some of those inclusion criteria. So it has to be from the offset of the trial development that the PI or the primary investigator is thinking about what population are we serving and how do we want to develop a trial that would be inclusive of all individuals, minorities included, and underserved, those that have a difficult time understanding research. So trial design has a big role in how we accrue to these trials once they're developed.
So that's a perfect segue, Peggy. So now we turn to the meat of the matter. So what are some good strategies for increasing African American recruitment? And I like to focus both on strategies that we can use at the community level as well as strategies at the individual level.
So I think one of the big factors that I've found in the role of recruitment and outreach specialists at the Cancer Center is that I am embedded in the community. So I have a relationship with the individuals in the community. But not only do I have a relationship, I bring resources to our communities. I feel like one of the things that I really wanted to focus on in the role was ensuring that when UVA comes out or Centera comes out, we're bringing resources with their request. So when community and individuals and communities see that you're trying to build their health and wellness and you're trying to contribute to the improvement of their health and wellness, they have more of a realistic expectation that I can trust this individual. They don't just want to have me participate in research. They want me to be better and healthier. And I feel like having that voice in the community, having that presence in the community, that engagement in the community is valued by the community and the individuals. So being there before these individuals need us is so vitally important. So that building trust, educating and making them aware, ensuring that they know about what's happening in our institutions when it comes to the loss or lack of being able to access innovative care, new therapies. Make for sure these individuals know about that before the need arises.
I strongly agree. Engaging participants right from the beginning. So engaging the community, as Peggy said, before the need even arises. So building that relationship with the community right from the beginning. So it's most often researchers, we find ourselves going to the community to recruit once we've identified our research questions and then needing participants to answer to enroll in our study. But the best strategy is to engage the community and let them tell you what their needs are, what are the topics that are important to them, what are their health problems that they need addressed. So for instance, my research is focused primarily on cervical cancer. And so if I go into the community and the primary issue in the African immigrant community is cardiovascular health, my question on cervical cancer may not be something that is of importance to them. So recruiting becomes very difficult because they feel that it doesn't answer something that is important to me. So why should I even engage in this? So one, going into the community, and then communication. Once you're in the community, using language that is meaningful to them. So plain language. We often use jargons. It's easy to say pap testing or to say COVID-19 or SARS-CoV-2. Language like that may put some people off because they feel it's really medical. It doesn't relate to me. So breaking the terms down into layman terms on our recruitment flyers, and then the importance of representation. Once you go into the community to recruit, and I have found this very useful in my past research, when I have my research team representing the community that I'm recruiting from. So if I'm recruiting from African immigrant populations, going to the research with a research team that has African immigrants on the team. One, they understand the language of the people, they understand the cultural norms of the people I'm recruiting from. So when I go into that community, one, my research team speaks the language. For instance, if I'm recruiting Ghanaian immigrants, I have research team members who speak Twi, who speak Ga, who speak Pidgin. These are languages that are spoken in Ghana. So when I go into the community to recruit, it's easy. They're going in with a research team that does not understand the language of the people, that doesn't understand the cultural norms of the people. So it becomes difficult to even get some buy-in and trust. So building that relationship, one, using recruitment strategies that are useful to the community. Two, and then also communicating and understanding the cultural norms helps build that lasting relationship.
Thank you. So Jerry, I think the elephant in the room that you and I look like individuals who may have historically not have built a lot of trust in the African American community. I mean, let's face it. So, and Peggy is, I don't know if Peggy's disagreeing, but Jerry, how do you Okay, so but Peggy, well, I'll ask my question then, Peggy, if you want to, you can disagree with me. But Jerry, what are some of the techniques that you have used to build that trust within the community when you do community-based trials?
Sure. I'm going to actually build on what Peggy and Joycelyn have already said, and you've heard this, and you're going to hear it again. It's all about trust relationships, and I'll tell you, our experience was we were interested in the problem of asthma in the African American community of Atlanta, and we found a way to build trust. There are two ways, either through direct engagement, which we've heard about, but we instead leveraged a trust relationship between the African American church, the community churches, and its members. We leverage, it's an enduring relationship in those communities. And what we learned to do is, we've heard a lot about the team and who's on the team and communication. We learned we had to listen. We had to go in and openly listen and hear from the grassroots what the problems were and what was going to work in that church and for its members. And it was very humbling, but the process was beautiful. The process built trust. And then we did engage. We engaged with awareness and sensitivity of the needs of that church. And we engaged and we brought them something, and we brought them a relationship, and we brought them empowerment, and we equipped. And we did it that way from the beginning. It wasn't about us. And that really worked. And the last thing I'll say about our experience, and we recruited over 5,000 people to our programs over years, was it was sustainable. We maintained the relationship. So we followed through. We just didn't show up, get our data, say goodbye, thank you. No, we said, we're here for you. This is how you reach us. Invite us again. And we did. Some churches had 4 or 5 programs, and it was fun to go back. And we saw the same people again, and it became a human, relational experience. And it was one of the most meaningful things I've ever done. It was a joy.
Right.
Thank you. All right, Peggy.
Well,
You're going to disagree, Peggy.
I think Jerry answered it perfectly. You have the opportunity to have leverage if you connect with leaders as well, but other individuals in the community. And when you do it from the grassroots approach, it takes time to build those relationships. And not having that time sometimes is the issue. Not having the budget when you build a research trial to be able to find someone that have the language of capability. But there are technologies out there that support that, like the CIRCOM. There's iPads. There are things you can use when you don't speak the language that isn't nearly as effective as actually having an individual. But thinking about those things again, when you build the trials and when you are creating the inclusion criteria, you're looking at the comorbidities of all your participants out in the communities that you're expected to show up to your center. But I think, like Jerry said, going to those communities and being there with leaders is a great way to leverage that connection, but staying engaged after you've been able to do that so that they know you didn't just come there for the research, because you're gonna need them again if you're a crew and trying to keep those individuals as healthy as everyone else.
So does that cost money in between trials? How do you continue, or I'm sorry, go ahead, Peggy.
No, I agree. You have to continue the engagement. You have it at the disposal of the University of Virginia. We have great resources. We have a community outreach group. We have a community engagement group. We have people who can be out there in the field, and we need to be connected and collaborate effectively with all the resources within our institution to ensure that we're not just trying to do this as one island, but doing it as a group and saying, when I can't be there, you are. So when we leave those communities, when you go into the Latino community, one of the things I got to do is be engaged in a Latino outreach event a couple months ago. And that community still knows who we are, because when we leave there, we make for sure that they know about all the resources we have going on at UVA, not just when we want to talk about research, but when we want to talk about research. We want to pull key people in so that the message gets back to the community that there's new therapies out there that's being developed, and we want you to have the same right to the same care and the same innovative therapies as everyone else has. So we don't want you left out. And it's your right to have that same awareness as everyone else. So we make for sure they are aware that this information is for everyone. And continually doing that and following up with it, as Jerry said, is invaluable to being able to go back and again ask, hey, we have this new trial. Are you interested? This is what it's about, but making sure it fits the population that we're engaging.
So is there a role for going back and sharing the results of the studies?
Absolutely.
Joycelyn?
Absolutely. And my background has mostly been not clinical trials, but all community-based research. And so once we finish our research studies, the plan, and it's always part of the grant writing process when we're putting together the grants with plans of disseminating. And so going back and sharing the findings with the community. So for my doctoral study, I recruited African immigrant women. They completed surveys, and then we did interviews with them. And then once I finished, the plan was to go back into the churches where I recruited, the community organizations and the mosque where I recruited women from, to share my findings with them, and then share what it means to the community and how we can use that information to build on the resources that are in the community that can be useful to these women. But unfortunately, COVID hit, churches were closed, so we couldn't go back and share that. But that is the plan, to go back into the communities, because they are the ones who help us answer this question. So we have to let them know what that means to them. What did we find? What does it mean to us? And how do we use that information to build moving forward? So and that doesn't cost money. The most it will cost you as a researcher is your time. And if they gave you their time in filling out your surveys and asking questions, the least you can do is to go back and share that information with them as well.
And if you can't be the individual that go back, ensure someone goes back.
Yes.
Okay, thank you. So if you are in your clinic and you are enrolling a subject and that subject happens to be African American, we know at UVA that the likelihood that that individual subject is going to consent, not for all of our trials, but for some of those trials, is lower. Just
Yes.
the acceptance rate is sometimes lower. Are there particular things that you can say to, I mean, how does one approach that individual subject? Do you approach that subject a little bit differently than you would a subject who is not African American in order to increase that acceptance rate? Just the individual level.
That's a great question. And what I found is I do it personally. In other words, it's worked better when I have gotten the trust of the patient, established a relationship. And when they know me and my values and I listen, I then bring out, here's an opportunity, and I really have to search. I do a little private moment where I say, be as transparent as you can. Because I understand it's a little bit self-serving because you want to obviously recruit into trials, but is this really right for you? And go into it fully thinking this is for you to consider, and never push anyone. I always say there's more information, we'll answer your questions. Think about this, and I'm glad to, address your concerns. And do it in an atmosphere of openness and listening and learning.
So I totally agree with everything you just said. I think providers have so much power. They have no idea. We did a small study of about 25 women of African American and Latino and Asian descent. And I think some Native Americans. And what we found was they often referred to, if my doctor tells me about it and they think that it's something that might be helpful, I'm more apt to want to be part of it. But one of the other things I will say is I don't think that I do anything with African Americans differently than I do with a Caucasian patient or an Asian patient. But I have found that the African American patient has more questions because they are more concerned about the mistrust that have happened with research in the Tuskegee and all the other Henrietta Lacks. They are aware of that history, and that history means a lot. So you have to bring forward the transparency, as Jerry alluded to. And if you are willing to go to that space and be comfortable in that space and acknowledge and validate that it did happen, and the goal is never to have it happen again. I have not had the difficulty. In the Cancer Center, error accrual rate for minorities have been anywhere from 12 to 15% in my past 3 years. But we started out at 7 and 5. So I know the difficulty in accruing to African Americans, but I still will actually say that there wouldn't be a difference if we would go in with the same mindset without that bias of thinking that there's this mistrust, but be valid openly about the mistrust. Openly discussing it.
I know what Jerry and Peggy have said all boils down to the importance of building that relationship right from the beginning. And the only way you can build trust with someone is to show that you're being genuine and being very transparent as possible, letting them know what the pros and cons are, what to expect, what are the benefits, what are possible outcomes of the study, and letting the participants know or the patient know. Some of them will ask, what is it in for you as a researcher? So you being genuine with yourself as a researcher as well, and sitting down and reflecting and asking yourself, what is it that I'm looking for? What if I were to put myself in the shoes of this individual, what would I want to know? And so it's scary involving recruiting or getting involved in clinical trials. It's a scary thing for participants. If they're going to take medications, they want to know what are the side effects. So being transparent, let them know everything and not hide certain things. And also, as Peggy said, you don't have that built-in bias that, oh, African Americans are already going to say no. So I'm just quickly going to run through this because they will likely say no anyway. Be genuine and open as you would with any other participant. The color of the person's skin shouldn't dictate how you approach them.
Yeah, thank you, Joycelyn. That's an excellent point. So Americans are notoriously unaware of history,
Yes.
but not all Americans are unaware of history. And if you as the investigator are less aware of the relevant history than your subject, you are at a disadvantage. And it doesn't matter if that subject is African American, Hispanic, an immigrant from who knows where, a rural American, someone who's just maybe different from you in some way that that is not apparent to your eyes. But I think maybe that's part of the lesson. If you're unaware of the context, in particular the historical context, you as an investigator will be at a disadvantage.
Absolutely true.
Very valid point.
Yes.
Very valid.
Thank you. So special considerations then when recruiting immigrant populations. Joycelyn, this is obviously is a particular interest of yours. So anything we've missed that we have to be particularly cognizant of with immigrant populations?
The same, thank you, Jerry. And I believe when recruiting African, I can speak specifically to the African immigrants population. I'm from Ghana, grew up in Ghana. I belong to the African immigrants population here, community here in the in Virginia and the DMV area. When recruiting, one important thing is to know that one umbrella doesn't fit all. So researchers are very notorious or are well known, at least in the African immigrant community, for saying, for instance, I've recruited some Nigerian immigrants for my research. So the same strategies or the culture will possibly be the same as it is for Ghanaian Americans or Ghanaian immigrants. It is not. We all have cultural differences that may be subtle, some not so subtle, that make us very different. And also with language, African immigrants are highly educated individuals. We have a lot of people with at least a bachelor's degree or higher. So language barrier may not always be the issue. Yes, there are some individuals who speak French, and French or Portuguese may be their primary language, but approaching individuals with a mindset that they may not speak English will definitely push people back. They are not uneducated individuals. We speak English, we are highly educated, we understand research, but we may not know what it entails. Clinical trials may entail, or what it means to enroll in a research study. So with that, the researcher has to break that down in layman terms, but not insulting or condescending in that aspect. And also not using one umbrella term. So in research, usually when you see a lot of research studies, African immigrants and African Americans are all put under one umbrella. There are cultural differences that exist among these groups, and several studies have shown that our cultural behaviors have impacted our cultural norms have impacted our cultural behaviors, which impacts our health outcomes. So keeping that in mind as well, that there are cultural differences that exist among these groups that may impact them. And also the current political climate plays an integral role in whether or not people are interested, one, in enrolling in studies, and even talking to people that they do not know. So as a researcher, you keep that in mind, that yes, there's that historical background, but what is happening now politically also impacts us as immigrants a lot. So people are afraid of confidentiality issues. If I'm sharing information with you, who is going to see this? Does it impact my stay here as an immigrant? Does it impact my potential of getting a job in the future? So that also has to be something that the researcher has to be mindful of, that people may refuse to enroll in the study, not because they don't see the importance of it, but because you haven't built that trust with them yet for them to disclose information that they think might impact them over a long term. So those are some of the main things to keep in mind. And then a way to recruit. African immigrants use churches and the mosque, religious organizations, as a way to socialize. So when you're recruiting, going into the churches and going into the mosque, building relationships with the leaders and getting buy-in from the leaders is always a great way to reach individuals, participants at the individual level. So communication, building trust, going into the religious organizations, and keeping in mind the historical, cultural context, and also the current political climate has an impact on people's behaviors.
Excellent. Well, thank you, everybody. I've enjoyed this this discussion, and on behalf of iThrive, thank you for your participation, and we'll see you soon.
Thank you, Jim.
Thank you.
Thank you both.
Bye-bye.